Let's now talk about how we are going to manage a patient with disseminated intravascular coagulation. These patients are very sick. These patients are the ones which you are going to find out in the ICU, and DIC has a very high mortality, about 30 to 80% in some studies. So it is very important to act quickly and it is important to act decisively. The number one thing is to look for the cause. If you remove the cause, if for example, if you have an underlying sepsis, the most important thing is to correct that disorder. Or if we have a dead fetus that is the cause of DIC, it is very important to remove the fetus. If to remove the cause, that is the only curative treatment for DIC. If the cause is not removed, if the underlying malignancy is not treated, if the underlying coagulation disorder is not sorted out, then all the other treatments are basically symptomatic and they basically manage the various presentations of the DIC. But the number one thing is to treat the cause. If you treat the cause, that will get rid of the problem. So treat underlying condition, that is the major step. Along with that, then we manage the various signs and symptoms simultaneously. If the patient is actively bleeding or if the patient needs to undergo any invasive procedure like a dental procedure or for example, any type of invasive procedure, endoscopy or any catheter related studies, then or if the patient is actively bleeding, then we basically try to compensate for that bleeding by giving him with the various products which he is losing. For example, we can give the platelet transfusion to keep the platelet count above the 50 nanoliters per liters. Along with that, we can give the plasma or the factors concentrate. These are administered to keep the prothrombin time greater than 3 seconds prolonged, and also to keep the fibrinogen levels greater than 1.5 grams per liter. So the goal is to keep the prothrombin time less than 3 second prolongation, less than 3 second prolonged, and to keep the fibrinogen level up. And if we are having a greatly increased PT time or the fibrinogen level is very low, then we can replace them by the help of factors in the form of FFPs or in the form of cryoprecipitates. Vitamin K can be supplemented in case of vitamin K deficiency. In case of excessive hyperfibrinolysis, we can give antifibrinolytic treatment like aminocaproic acid can be given, transamine can be given, tranexamic acid in the form. So we can also employ the antifibrinolytic treatment along with the other types of replacement studies. Now, on the other hand, if we do not have any major bleeding or thrombosis, and if the DIC is not very symptomatic, then generally prophylactic heparin to prevent the thrombi, because thrombi are the major things which we fear in these patients. So prophylactic low molecular weight heparin can be tried in a smaller doses in these patients to stop them from making thrombi further or to stop the progression of the thrombi. If the patient has overt thrombosis or thromboembolism or the organ failure which is related to the clot formation, if there is widespread thrombosis, then in that patient, and if the various organs of these patients are failing, if the kidneys are shutting down or the patient is presenting with a stroke or the patient is presenting with pulmonary abnormalities, then it is very important to start therapeutic anticoagulant treatment with low molecular heparin and later on transitioning into the warfarin orally. And then it is very important to act quickly in these cases because these systems or these symptoms can aggravate very quickly, and these can lead to multi-organ failure in this patient. And that can lead to a picture which we generally term under the umbrella as the severe immune compromise. These patients can be severely debilitated, and this leads to high mortality and morbidity in these patients. So it is very important and imperative to quickly start off a therapeutic anticoagulant regime like low molecular weight heparin or certain newer types of the low molecular weight heparin derivatives, certain types of warfarin derivatives, dabigatran. These can be tried orally, certain newer drugs. So along with that, it is important to restore the natural anticoagulant pathways. These are generally under evaluation in the clinical studies. We can give them from outside the various types of natural anticoagulants like the protein C and protein S. They are recombinant forms which are being tried under clinical studies. These can be transfused into the patient, or we can use certain drugs that can promote or activate these natural anticoagulant pathways. So this was an overall view of how we are going to manage a patient with DIC. The number one thing is to treat the underlying cause, and along with that, we treat what is wrong with the patient. If the patient is bleeding, we give them platelets. We give them. If the patient is anemic, we give them RBCs. RBCs. If the patient is uh, having vitamin K abnormalities, we give them vitamin K supplementation, antifibrinolytic treatment if there is excessive hyperfibrinolysis. If there is no major bleeding or thrombosis, then we give prophylactic heparin, and if there is widespread thrombus formation, then we give aggressive anticoagulant treatment. With that, we complete our discussion of DIC, or disseminated intravascular coagulation. It is a very important clinical condition. It is very important to understand the basic pathophysiology. We started off by talking about what are the basics, what does the term mean. Then we looked at the various causes. We discussed the pathophysiology in great detail, what are the clinical symptoms with which a patient presents, and finally, what are the important labs to look for, what are the labs to follow, and in the end, we discussed in detail how we are going to manage a patient with DIC. I hope you have learned something from this lecture, and I'm going to see you in another lecture. Thank you for watching sqadia.com.